Muy buenas noches a todos los que ya están conectados para esta sesión extraordinaria de la Agrupación Mexicana para el Estudio de la Hematología, en donde el tema es medicina transfusional. Debo decirles que esta sesión es un ejemplo de algunas sesiones que quisimos incorporar en el programa educativo anual de las sesiones que ocurren mes tras mes, aún a pesar de que en algunos de estos temas no hubiera un interés claro ni un apoyo de la industria farmacéutica, porque no son temas que les interesen tanto. Sin embargo, consideramos nosotros, y así se hizo el programa, que hay una serie de temas que no pueden estar ausentes de la actualización académica que todos tenemos a través de la agrupación, y por eso incluimos estos temas, además de, claro, los temas en donde la industria participa. Pero esta sesión, creo yo, es muy importante, además con dos temas que son muy relevantes. Uno para el trasplante de progenitores hematopoyéticos, y el otro en la transfusión de plaquetas, que es una de las circunstancias que sigue ocurriendo con mucha frecuencia en nuestros pacientes hematológicos. De tal forma que voy a dejar la palabra a la doctora Demichelis, no sin antes agradecer a los ponentes que ella presentará, que nos brindarán dos exposiciones, y al final de las cuales habrá una sesión de preguntas y respuestas. No olviden ustedes ir haciendo las preguntas para que vayan captándolas y podamos al final tener una buena sesión con todas sus dudas y comentarios. Adelante, Roberta, por favor.
Muchas gracias, doctor Meillón, y gracias a todos por estar aquí. Bienvenidos a esta sesión extraordinaria donde tocaremos pues dos temas muy interesantes de medicina transfusional. A nombre pues de toda la mesa directiva que preside el doctor Meillón, les damos la bienvenida. Y antes de pasar a presentarles nuestra agenda y a los ponentes, les recordamos que este sábado tenemos una de nuestras sesiones de sábados que llamamos Brunch con los expertos, que pues son virtuales, entonces cada uno se tendrá que preparar su propio brunch, pero será una sesión muy, muy interesante sobre enfermedad de injerto contra huésped este sábado a las 10 de la mañana. El registro pues lo podrán ver a través de las redes sociales y de la página de la AMEH, y tendremos estos tres subtemas muy interesantes de enfermedad de injerto contra huésped durante 3 horas este sábado por la mañana. Entonces no olviden pues registrarse terminando esta sesión para estar ahí. Y les presento a nuestros ponentes del día de hoy. Nuestro primer ponente, que seguramente todos ustedes conocen muy bien, es el doctor Sergio Sánchez. Él es médico internista y hematólogo formado en el Instituto Nacional de Nutrición. Tiene además una alta especialidad en medicina transfusional en Nueva York. Él fue jefe de banco de sangre tanto del Instituto Nacional de Nutrición y durante muchos años del Instituto Nacional de Cancerología, y actualmente pues se desenvuelve en la medicina privada. Es miembro del Sistema Nacional de Investigadores, autor de múltiples publicaciones, revisor de algunas revistas y miembro de sociedades internacionales. El doctor Sánchez pues es realmente un experto en medicina transfusional, y él tocará el tema en específico de incompatibilidad ABO y Rh en el contexto de trasplante de células progenitoras hematopoyéticas. La siguiente charla la dará la doctora Claudia Cohn, que nos acompaña el día de hoy. Ella es patóloga clínica formada en Cornell en Nueva York, con alta especialidad en medicina transfusional, un doctorado, editora pues de múltiples manuales y revistas internacionales. Ella es actualmente la directora médica del Banco de Sangre de la Universidad de Minnesota, también directora médica asociada del laboratorio de HLA, y ella tiene un particular interés en transfusiones plaquetarias. Y justamente el tema que tocaremos con ella, que es un tema pues muy interesante y muy relevante, es acerca de refractariedad plaquetaria. Y antes pues de darles la palabra a nuestros ponentes, Les recuerdo que en la plataforma pueden elegir el idioma en el que quieran escuchar la sesión. El doctor Sánchez pues hablará en español, pero la doctora Cohn hablará en inglés, pero pueden elegir si quieren escucharla en el idioma original o si quieren escuchar la traducción simultánea. Están las dos opciones. Les recuerdo también que todas las preguntas que vayan teniendo las metan en la plataforma a través del icono para subir preguntas. Nosotros las vamos a ir recibiendo y al final tendremos un muy buen espacio de tiempo para preguntas y respuestas. Cuestiones técnicas con la plataforma es otro icono que está abajo por alguna duda de cuestiones técnicas. Y finalmente, antes de dejar a nuestros ponentes hablar, les recuerdo que descarguen la constancia de la sesión antes de que termine la sesión. Y pues nada más les agradezco a nuestros dos ponentes por tomarse el tiempo y por la disposición que tuvieron para estar con nosotros el día de hoy y pues les cedo la palabra.
Bien, pues buenas tardes, buenas noches a todos ustedes. Es un honor estar nuevamente en estas sesiones de la AMEH. Agradezco infinitamente pues la amable invitación al doctor Meillón, a la doctora Roberta Demichelis, el permitirme tocar este tema en los próximos minutos respecto a lo que es el trasplante de células progenitoras aunque verán que haré un breve repaso a través del tiempo, me enfocaré en algunos puntos muy específicos, algunas dificultades, vicisitudes, por qué no decirlo de repente, algunos imprevistos, pero que serán muy importantes para el éxito del programa de trasplante en los pacientes que así lo requieren. Bien, decía yo que haré un breve viaje a través de lo que es la historia de los trasplantes y bueno, es de reconocer obviamente el trabajo del grupo del doctor Thomas, como ven ustedes ya hace más de 60 años, como pionero en el trasplante de células hematopoyéticas. Esta fue una de sus primeras publicaciones. Gracias a él es una realidad que una gran cantidad, cientos de miles, millones de pacientes muy probablemente alrededor del mundo se hayan beneficiado hoy en día y lo seguirán haciendo a través del tiempo por todo este desarrollo de estos trabajos inicialmente en médula ósea. Sabemos que la célula progenitora hematopoyética tiene un inmunofenotipo único, muy peculiar, pero para tratar de ir contestando la pregunta que es el motivo del título de esta charla, el por qué podemos hacer trasplantes de células hematopoyéticas independientemente del grupo sanguíneo, del donante y del receptor, está resaltado aquí. Precisamente esta célula es tan inmadura que no expresa aún antígenos de grupo sanguíneo. Y hablaba yo de los orígenes de los programas de trasplante de células progenitoras, en donde era exclusivamente la fuente, la médula ósea, pero hoy en día tenemos también ya la sangre periférica e inclusive sangre de cordón umbilical en uso clínico y en investigación una fuente todavía mayor, como pudiera ser inclusive el líquido amniótico, aunque hasta donde sé, nadie lo ha utilizado hasta hoy con fines clínicos. Esta es un poco la evolución histórica de las fuentes de células progenitoras. Ven ustedes en barras azules y como todavía hasta el siglo pasado la única fuente para este fin era la médula ósea, pero en barra verde, como a partir de este siglo se ha venido incrementando significativamente y de hecho hoy en día es la fuente principal de abasto y recolección de células hematopoyéticas a través de la sangre periférica. Y la barra naranja, el uso de la sangre de cordón umbilical como materia prima y como proveedora de estas células hematopoyéticas, pero como muestro en esta otra diapositiva, en donde se comparan la parte superior, los cuadrantes superiores de estas gráficas, hablan de la supervivencia en niños. En el cuadrante con el inciso A es en niños europeos, el cuadrante B es la comparación con los niños norteamericanos, y en los cuadrantes inferiores nuevamente es en el C el europeo, el D la población norteamericana, pero población adulta. Como ven ustedes, la fuente del cordón umbilical es más socorrida, mucho más socorrida, definitivamente en población pediátrica que en la población adulta. Gracias a todos estos avances en la medicina, el programa de trasplante se ha difundido y se ha diseminado a muchos países a nivel mundial, que es el fin de beneficiar a la mayor parte de pacientes que lo requieren en el mundo, y en México no es la excepción. En este caso, en 1980 se realiza el primer trasplante de médula ósea en el Instituto Nacional de Nutrición por el grupo de la doctora Córdoba, junto con el doctor Eucario León y el doctor Ricardo Sosa, quien ya falleció, pero el doctor Sosa fue el pionero y fue un alumno precisamente del doctor Thomas, quien trajo esta modalidad de tratamiento a nuestro país. Hoy en día hay casi una veintena de instituciones que realizan trasplante de este tipo en todo el país, y hasta el año 2017, que son las estadísticas más recientes que pude localizar, ya se habían realizado más de 6,000 trasplantes de este tipo en nuestro país. Este es un listado de instituciones en donde pueden ustedes apreciar que hay instituciones públicas, instituciones privadas y sobre todo Ciudad de México, Puebla, en el centro del país, pero también en el occidente como Guadalajara y en el norte como Nuevo León. En este caso, el rol que tiene el banco de sangre en el programa de trasplantes de células hematopoyéticas en general, aquí lo enlisto, va desde la cosecha y la criopreservación de estas células, el apoyo transfusional apropiado y oportuno para los pacientes en estos programas, la inmunoterapia, también el banco de sangre participa cuando es necesario infundir linfocitos del donante, por ejemplo, y aunque en México aún no contamos con la capacidad de manejar terapia celular, ya hay ingeniería de tejidos en el Instituto Nacional de Rehabilitación con el que hemos también colaborado, pero esta es una puerta a una ventana adicional para la actividad del banco de sangre en este tipo de programas. Comenzaré con lo que es la cosecha de células, en este caso sangre periférica. Sabemos que la célula progenitora, su hábitat es definitivamente la médula ósea, y para poder cosecharlas a través de sangre periférica es necesario movilizarlas. Hoy en día esto se logra gracias a los estimulantes, los factores estimulantes de colonias de granulocitos en su gran mayoría, y esto hace que podamos nosotros tener, cuantificar y cosechar las células progenitoras con el fenotipo CD34, pero también obviamente se pueden movilizar otro tipo de células de la médula ósea hacia la sangre, incluyendo los linfocitos totales. Estos factores, junto con otros más recientemente como el plerixafor, actúan a nivel de microambiente de la médula ósea, y esto favorece que las células progenitoras puedan circular en la sangre. Una vez que se logra esto, se lleva a cabo la cosecha, habitualmente entre el día 4º y el 6º de haber iniciado la movilización con factores estimulantes. Se ha visto que manejando dosis adecuadas de células progenitoras, el riesgo de desarrollar enfermedad contra hospedero realmente se reduce y es manipulable en la mayoría de las veces. Hoy en día también contamos, inclusive en México, con estos productos. Hablaba yo ya del Prexafor, pero también el factor estimulante de granulocitos pegilado, que se puede llegar a utilizar en algunas circunstancias. El Prexafor, sobre todo, se utiliza para los trasplantes autólogos, dado que con el factor estimulante de granulocitos es más que suficiente para movilizar cuando el donante es sano y es un donante halogénico. Otro punto que en un momento dado causó mucha inquietud era la seguridad hacia el donante, hacia una persona sana, de estar recibiendo agentes como los factores estimulantes y que esto a la larga no le trajera ningún perjuicio para su salud, pero precisamente aquí muestro esta publicación del 2014 en donde esas inquietudes prácticamente se desvanecieron y podemos decir hoy en día que el donar células progenitoras es un procedimiento seguro para cualquier persona que así lo desee hacer. Sabemos que no es la panacea, que hay indicaciones muy precisas y son precisamente en su mayoría problemas neoplásicos hematológicos, síndromes de falla medular, y en el caso del INCAN, prácticamente el único tumor sólido que se maneja con un programa de trasplante es el tumor de células germinales testicular. Hablaba yo de las fuentes de obtención en el INCAN, en obtención prácticamente en la mayor parte de instituciones donde se trasplantan adultos. La fuente más favorecida es la sangre periférica, seguida de la médula ósea, y la sangre de cordón umbilical, insisto, va sobre todo para la población pediátrica o en adultos de muy bajo peso por la cantidad, sobre todo del volumen en el cual se conservan estas células de cordón umbilical. Estos son los esquemas de movilización, sea el de únicamente factor estimulante de granulocitos, o bien en pacientes bajo el programa de trasplante autólogo, se puede utilizar ciclofosfamida más el factor estimulante. Decía yo que las cosechas generalmente se inician a partir del cuarto, quinto y sexto día, con la condición de que haya suficientes células CD34 en sangre periférica, y esto se mide a través de la citometría de flujo. Nosotros en el instituto llegamos a establecer como mínimo 7 células CD34 por microlitro, pero habrá otras instituciones que manejen cifras todavía más elevadas de células CD34 por microlitro para poder cosechar a los pacientes y conectarlos a las máquinas de aféresis. Para aquellos que están interesados, que están por empezar algún programa de esta naturaleza, obviamente por el costo, la tecnología de manejar citometría de flujo, surge la pregunta que se aclaró desde hace muchos años de si ir con la biometría, la cantidad de leucocitos y el porcentaje de células mononucleares bastaría, pero vean ustedes cómo no hay ninguna correlación entre la cifra de leucocitos y el porcentaje de células mononucleares con las células CD34 cosechadas. A diferencia de la medición precisamente de estas células CD34 en sangre, en donde aquí la correlación, como pueden ver ustedes en esta gráfica, es casi perfecta. Vamos así más a la segura. El otro punto muy importante para los bancos de sangre es el control de calidad. Este no debe faltar bajo ninguna circunstancia, y es primero saber que haya la dosis mínima indispensable para poder asegurar el injerto de estas células y en este caso la dosis mínima debe ser de 2 millones por kilogramo de peso. A partir de allí ya podemos ir incrementando las dosis de células obtenidas, pero tomar la precaución que obviamente en los casos de trasplante de halogénicos, el rebasar 8 millones de células CD34 por kilo de peso podría incrementar el riesgo de que el paciente desarrolle enfermedad de injerto contrahospedero. El otro punto, además de la dosis que se va a infundir al paciente, es el que el producto sea estéril. Cultivos microbiológicos negativos con la salvedad, se puede hacer una excepción, más adelante abundaré al respecto, de la contaminación por Staphylococcus epidermidis. Y el tercer punto de este control de calidad tendrá que ser que las células CD34 cosechadas e infundidas sean viables, tengan una viabilidad de al menos el 80%, también idealmente medido por citometría de flujo. Los equipos, ya hay varios en el mercado muy eficientes. Hoy en día vamos mucho por estas dos marcas, Optia y Amicus. En cualquiera de ellas se procesan de 3 a 4 volúmenes sanguíneos para también que la máquina programada tenga la oportunidad de cosechar la dosis mínima necesaria. Cuando es un trasplante halogénico, dado que el donante es una persona sana, generalmente no hay dificultades para obtener la dosis requerida, inclusive en 1 o 2 sesiones como máximo. En cuanto a la conservación, si estas células se van a infundir prácticamente de inmediato, en un máximo de 5 días a partir de que fueron cosechadas, no es obligada la criopreservación. Se pueden refrigerar sin ningún tipo de crioprotector, pero si no se van a utilizar de inmediato, sí será necesario criopreservarlas con la debida crioprotección. La criopreservación se puede hacer hasta por un máximo de 6 meses utilizando ultracongelación mecánica a menos 80 grados centígrados, pero si las células se van a almacenar por más de 6 meses, sí será imprescindible el que estas células se conserven a menos 196 grados con el nitrógeno líquido. Y en cualquier modalidad de criopreservación, de congelación, habrá necesidad de proteger a la célula de cualquier daño físico por la congelación a través de estos crioprotectores. Un crioprotector intracelular como es el dimetilsulfóxido o DMCO y un crioprotector extracelular como es el GES o hidroxietilalmidón. Ahora, en cuanto al apoyo transfusional, que es el otro papel que juega el banco de sangre en estos programas. El riesgo de sensibilización por HLA, y esta es también una confusión que a menudo surge en algunos de nosotros como hematólogos. El riesgo de aloinmunización por HLA se previene utilizando la leucodepresión por filtración. Filtros de 3ª, 4ª generación nos pueden ayudar mucho para evitar que un paciente se sensibilice, inclusive desde el apoyo transfusional inicial en el manejo de sus neoplasias, sobre todo cuando hay quimioterapias de por medio, quimioterapias mielosupresoras, la transfusión de plaquetas de eritrocitos filtrados será muy importante y podrá hacer posible que el paciente llegue sin que esté sensibilizado al trasplante. Y por otro lado, la enfermedad de injerto contrahospedero post-transfusional, esa no se previene filtrando los productos sanguíneos, sino irradiando estos productos sanguíneos cuando hay un componente celular de por medio. En este caso, cualquier concentrado eritrocitario, cualquier concentrado o aféresis de plaquetas que se vaya a transfundir a estos pacientes, ya en el programa de trasplante de células progenitoras, sí será necesario irradiar el producto para eliminar los linfocitos viables y que estos no vayan a anidarse en la médula ósea del paciente y vayan a atacar inmunológicamente a su organismo. Esto lo logramos empleando una dosis de radiación de entre 1500 y 3000 centigrados. Menos de 1500 podrían quedar linfocitos viables en el producto sanguíneo y ocasionar la enfermedad de Hurtado hospedero. Más de 3000 centigrados, entonces podríamos empezar a dañar las células que quisiéramos transfundir, sean eritrocitos, sean plaquetas. El otro punto importante es que cuando un concentrado eritrocitario se irradia, la vigencia del mismo también se modifica, se reduce de 42, 35 días, según el tipo de bolsa que se utiliza, pero a partir de que se irradia, la vigencia es de 14 días. Y después del 5.º día de irradiación, si ese producto no se ha transfundido, sí se puede ir incrementando la acumulación de potasio en el sobrenadante, y cuando se vaya a transfundir, sobre todo en pequeñitos, en población pediátrica o en pacientes nefrópatas o con alguna alteración en el funcionamiento renal, será muy conveniente el lavar el producto para eliminar esa concentración acumulada de potasio. En el caso de no contar en el momento con productos irradiados, una opción pudiera ser hoy en día el uso de agentes inactivadores de patógenos, pero concretamente los que utilizan fuentes de luz ultravioleta, sea con riboflavina como el Mirasol o con soralenos como el Intercept. Decía yo que entonces el empleo de productos irradiados, sobre todo, será cuando el paciente ya es el candidato y se abre todo el protocolo de ingreso y estudios al programa de trasplante de células progenitoras hematopoyéticas. En el caso de las unidades negativas para citomegalovirus, dependerá de la población de pacientes. Si son niños, por ejemplo, que sean serológicamente negativos para citomegalovirus, sí será necesario transfundir unidades CMV negativas. En algunos países, sobre todo los industrializados, tienen bancos de células CMV negativas. En México carecemos en realidad de ellos, pero una alternativa es nuevamente la leucodepresión con filtros de tercera y sobre todo cuarta generación. En el caso de los adultos, si el binomio donante-receptor son CMV negativos, que insisto, en adultos es muy poco frecuente, tendríamos obligadamente que ir con unidades negativas para el sistema virus, definitivamente. Insisto, la filtración por la leucodepresión por filtración previene estas infecciones en los pacientes trasplantados. Y el otro punto que es muy importante que se haga desde el inicio de la incorporación del programa de trasplante por parte del banco de sangre es la titulación de las isohemaglutininas en el receptor, siempre y cuando haya una incompatibilidad ABO con el donante, en cualquier sentido, sea esta incompatibilidad mayor, menor o bidireccional, como más adelante voy a profundizar un poco más. Si esta titulación de isohemaglutininas fuera igual o mayor a 1:128, entonces será necesario que el paciente se someta a sesiones cotidianas de plasmaféresis o de recambio plasmático para bajar este título a menos de 1:16. Si además lo que se va a infundir es médula ósea y no sangre periférica, la médula tendrá que depletarse de eritrocitos. La sangre periférica no es necesario, puesto que el volumen de eritrocitos que se cosecha finalmente por las máquinas de féresis es mínimo, pero cuando se obtiene médula, sí, la cantidad de eritrocitos que contamina esa bolsa, ese litro y medio de médula que se le va a infundir al paciente, sí puede ocasionar reacciones transfusionales en estos casos. Lamentablemente, el procesamiento de la médula ósea para depletar de eritrocitos provoca una merma muy considerable de células progenitoras hematopoyéticas. Ese sería, desde mi punto de vista, uno de los grandes inconvenientes y retos cuando se requieren este tipo de procesamientos en la médula ósea. Hay protocolos ya publicados, muy establecidos, como el que aquí muestro, en los cuales nos podemos y nos debemos obviamente apoyar para hacer las aféresis y poder disminuir los títulos de estas isomaglutininas. En estos casos nos recomiendan cuántos volúmenes plasmáticos debemos procesar, entre 1 y 1.5 volúmenes plasmáticos totales, con una frecuencia cotidiana, y las soluciones de reemplazo, que sería pues más prácticamente la albúmina para estos procedimientos. Esta tabla también es muy importante. Yo siempre trataba de que en el laboratorio de inmunohematología, en el banco de sangre, se tuviera a la vista, porque es muy práctica, por lo menos para mi gusto, así resulta. Y aquí tenemos, voy a intentar señalar 3 casos para incompatibilidad mayor ABO, la incompatibilidad menor y la incompatibilidad mayor y menor o bidireccional. ¿Cuáles son estos casos? Bueno, en la incompatibilidad mayor, los antígenos de las células del donante van a resultar incompatibles con los anticuerpos del suero del receptor. Es el caso, por ejemplo, de pacientes que, siendo del grupo O, van a recibir células de un donante de grupo A o de grupo B. A eso nos referimos con la incompatibilidad mayor. Hay 4 etapas muy importantes también a considerar. Están señaladas en la parte superior de la gráfica e inicia con el régimen de precondicionamiento. La siguiente etapa será el día 0, al momento de la infusión de la médula ósea, o sea, de las células progenitoras de sangre periférica. Después, en la etapa post-trasplante, el siguiente punto crítico será la determinación de los anticuerpos hacia el donante, esto obviamente en las muestras del receptor, que se puede hacer con la prueba inversa, y el CUMS directo, cuando este sea negativo. Y el último punto crítico sería el que ya no se detecten células del receptor, del grupo sanguíneo del receptor. Recordemos que cuando hay un trasplante de esta naturaleza, va a haber una transición, va a haber un cambio finalmente de grupos sanguíneos, y aquel donante o aquel paciente que inicialmente era de grupo O va a terminar convirtiéndose en un paciente de grupo A o B, según el grupo sanguíneo de las células que le fueron trasplantadas. Y aquí, en este código de colores, pueden ver ustedes cómo en la parte superior hay el tipo de eritrocitos, el grupo sanguíneo de eritrocitos que vamos a transfundir en código oscuro totalmente. No puedo lamentablemente visualizar el cursor, pero en la parte inferior ven a qué corresponde. La barra oscura corresponde a la transfusión de eritrocitos con el grupo sanguíneo del receptor, que podemos estarlo utilizando durante todo el tiempo, desde el régimen de precondicionamiento, el día 0 de la infusión, hasta que ya la prueba inversa nos salga negativa para los anticuerpos hacia las células del donante y el CUMS directo se haya vuelto negativo. A partir de ese momento ya podemos hacer el cambio a transfundir eritrocitos de las células tipo sanguíneo del donante. En el caso de las plaquetas es la barra inferior. Las plaquetas podrán ser del tipo del donante, en este caso A o B, a partir del régimen de precondicionamiento. En el caso de la incompatibilidad ABO menor, es decir, el binomio opuesto, precisamente en donde el paciente, siendo de grupo A o de grupo B, va a recibir células de un donante de grupo O. Entonces, hay más flexibilidad en la transfusión de los eritrocitos que pueden ser a partir del régimen de condicionamiento del tipo del donante, es decir, en este caso de grupo O, pero serían las plaquetas las que sí van a seguir siendo del grupo sanguíneo del receptor hasta que las células del receptor ya no sean observables en las pruebas inmunohematológicas, las pruebas de compatibilidad. Y en el caso de incompatibilidades bidireccionales mayor y menor, en donde aquí pues prácticamente es el paciente de grupo A que recibe células de un donante de grupo B o viceversa, pero es siempre A contra B, pues aquí la alternativa es ir a la segura y apoyarnos en eritrocitos de grupo O y en plaquetas de donantes de grupo AB hasta que el CUMS directo sea negativo y ya no haya en la prueba inversa la detección de anticuerpos anti-A o anti-B. Y todo esto se hace con la idea de disminuir los riesgos, por un lado, de hemólisis al momento de la infusión de estas células en el día 0, sobre todo cuando hay incompatibilidad de grupo ABO mayor, o bien la aplasia pura de la serie roja, que puede ser también otra complicación en este tipo de incompatibilidades mayores. Podemos observar también un retraso en que el injerto prenda y empiece a funcionar, o bien se ha descrito en el caso de las incompatibilidades ABO menores la hemólisis por un mecanismo inmunológico que llamamos transferencia pasiva del linfocito pasajero. Esta modalidad, yo en lo personal la he visto particularmente en los trasplantes de órganos sólidos, pero también se han descrito casos en el caso de trasplantes de células progenitoras hematopoyéticas. Y aquí un caso de la vida real, que si bien no tengo todos los datos conmigo, se los resumo, es la información que yo tengo, dado que en algún momento me pidieron una opinión hace ya algunas semanas atrás. Se trata de una mujer con una leucemia aguda que se sometió a un alotrasplante con incompatibilidad mayor ABO, insisto, ella es de grupo sanguíneo O, y su donante era de grupo A. Sin embargo, 6 meses después de haber recibido el trasplante, la paciente sigue con altos requerimientos transfusionales de concentrado eritrocitario, de tal grado que amerita 2 unidades de concentrado eritrocitario cada 15 días, porque como ven ustedes en la columna derecha, viene manejando anemias de 5 gramos con una cuenta de reticulocitos del 1.5%. Al momento de analizar el quimerismo, se vio que este quimerismo es del 94%, es decir, es una realidad que la paciente o que el injerto ha aprendido, pero la paciente 6 meses después continúa siendo de grupo sanguíneo O positivo. No ha hecho esa migración a grupo A, que era es lo esperado. Del estudio de médula ósea, únicamente cuento con información de que la eritroide se describió como muy disminuida y que la titulación de isomaglutininas, no tengo información pre-trasplante, pero post-trasplante era de 1 a 16 con una especialidad de anti-A1. Y aquí esta es la imagen que se ve en el banco de sangre, en donde las columnas de gel para determinar el grupo A y el grupo B, los eritrocitos se precipitan hasta el fondo, es decir, es negativa, mientras que para el RH, el antígeno D, es positiva, de tal manera que la paciente efectivamente sigue siendo de grupo directo O positivo, y en el grupo inverso, los anticuerpos anti-A1, anti-B, hacen que también salga intensamente positivo, lo que es definitivamente compatible con que la paciente sigue siendo a estas alturas de grupo O y no ha hecho la migración de grupo sanguíneo. Otro punto a considerar es la contaminación de estas células sea por la cosecha, sea por la manipulación a la cual se someten en el laboratorio. Y en un análisis que se hizo de más de 300 unidades que se cultivan, porque es parte, obviamente, decía yo, del control de calidad en cada cosecha que se obtiene de los donantes, 21 de 366, es decir, el 5.7%, resultaron positivas para los cultivos microbiológicos. Y en este caso, los gérmenes que se cultivaron fueron en su gran mayoría, como ustedes pueden apreciar, un Staph epidermidis y afortunadamente en la gran minoría el Staph aureus, pero sí también hubo gérmenes gram negativos en algunas otras unidades. Entonces, ante esta circunstancia, ¿qué es lo que se debe hacer? Bueno, en esta tabla hago una comparación de la casuística que se analizó en el INCAN, que es más comparable con hospitales como el de Porto Alegre en Brasil o en Turquía que en los hospitales de Estados Unidos, en donde, aunque también no están libres de este riesgo de contaminación, la prevalencia es mucho menor. ¿Qué se puede hacer en estas circunstancias? Bueno, hay que analizarlo en el interior del comité de trasplantes, pero cuando una unidad se contamina con un Staph epidermidis, dado que es un producto muy valioso y de eso depende muchas veces la vida del enfermo, se pueden infundir, pero con el manejo previo de antibióticos para los cuales el Staph epidermidis demostró ser sensible antes, obviamente, de intentar infundir estas células. En el caso del Staph aureus, definitivamente que esas unidades, por más valiosas que sean, tendrá que dársele destino final y no proceder definitivamente al trasplante. Este es algo muy relevante también para la viabilidad del programa y definitivamente para la vida de los enfermos. Por eso es muy necesario que se instale un programa de biovigilancia para que se vea la seguridad no tan solo transfusional entre donante y receptor, sino también la seguridad de los trasplantes, tanto de órganos como tejidos, en este caso células progenitoras, tanto velar por la seguridad del donante como velar por la seguridad del receptor. Cuando tengamos ya en nuestro país el acceso a la terapia celular, que espero no demore demasiado, será también obligado incorporarlo a un sistema de vigilancia e inclusive esto ya se viene haciendo con el programa de recolección de productos biológico infecciosos. Mis recomendaciones serían definitivamente el que antes de que se desarrolle un programa de esta magnitud de trasplantes de células progenitoras, se registre la institución y el programa ante el Centro Nacional de Trasplantes, aplicar siempre y en todo momento el principio científico, es decir, el estado del arte, la creación y las reuniones periódicas del Comité Institucional de Trasplante para analizar los casos nuevos, los casos ya trasplantados y como el que presenté, los casos complicados para que juntos se encuentre la mejor solución. Definitivamente la creación de una normativa que regule todos estos puntos será muy importante. ¿Qué sucede en nuestro país? Bueno, esta normativa se envió ya desde hace años a la Secretaría de Economía, a la COFEMER, previo a su publicación y oficialización en el diario oficial precisamente de la Federación, pero lamentablemente anteayer que entré a la página de la Secretaría de Economía, adivinen que este proyecto de modificación de este proyecto de la norma oficial mexicana de trasplantes de las progenitoras sigue en revisión casi 7 años después de haberse enviado. De tal manera que, dado que los avances científicos van a mucho mayor velocidad que los avances legislativos, entonces el banco de sangre tendrá que estar a la altura y al día para no limitarse únicamente a ser proveedor de productos sanguíneos, sino de participar activamente en la atención de calidad en estos pacientes hemato-oncológicos que se van a incorporar a este tipo de programas de trasplante, y que cuando se abra la terapia celular, entonces el involucro y la responsabilidad también tendrá que ser apegada a este estado del arte. Finalmente, una frase milenaria, ¿sí?, que nos legó Julio César en el Imperio Romano y que es todavía aplicable, ¿sí? Si vis pacem para bellum, es decir, si quieres la paz, prepárate para la guerra. Si queremos que todo marche en orden con nuestros programas, tenemos que estar al pendiente y dar puntual seguimiento a casos como los que he comentado en estos minutos, que ahora concluyo. No sin antes nuevamente agradecer la atención de todos ustedes y la invitación de la que fui merecedor esta tarde. Muy amables. Gracias.
Hello, and thank you to the Mexican Society of Hematology for inviting me to give this presentation today on platelet transfusion refractoriness. How do I diagnose and manage this problem? I have no relevant disclosures. Today, I will be covering the following. In this presentation, I will describe the role of immune-based factors in causing platelet refractoriness. I will describe how to diagnose platelet refractoriness. I'll describe different testing modalities that we use to determine that a patient is refractory to platelets and to obtain compatible platelets for these patients, and understand the availability and relative advantages of different compatible platelet products for a patient with platelet refractoriness. So I'm going to begin this case today by talking about 2 patient cases that came to me a few years ago. Patient A was a 65-year-old female with a history of chronic myelomonocytic leukemia, CMML. She was treated with chemotherapy and followed with bone marrow biopsies. In 2018, when she first presented, she had 4.8% blasts in her marrow. And today, or rather on March 2020, when she presented to the emergency room, they did a bone marrow biopsy and she had 100% cellularity and 14% blasts. So they admitted her and started chemotherapy. Patient B, on the other hand, was a 42-year-old female with a history of AML, leukemia, and she also had had an allogeneic stem cell transplant in 2019. On March of 2020, this patient presented to the emergency room with shortness of breath, shingles, and fever. Her CBC at the time showed profound leukocytosis, a white blood cell count of 258, and 81% circulating peripheral blasts, concerning for a relapse of her AML. I came to know these patients a few days later. They had been in the hospital for a while, and one night my pager went off several times. The first time my pager went off, it was about patient A. They were calling, the hematology team was calling the blood bank saying, patient has a history of platelet refractoriness. Can we get specialty platelets to support her? Of note, when I looked her up, I saw that she had a pregnancy history. She had been pregnant 7 times, G7P5. And in the past, when they had tried to provide compatible platelets for her, they had found that she was incompatible by platelet crossmatch to most of the platelets that they tested. In fact, they tested 14 platelets. She was incompatible to 13 of those 14 platelets. They wanted to keep her platelet count above 20,000 because she had some mucosal bleeding. She had petechiae in her mouth. And in our hospital, they try to keep patients above 20,000 if you have evidence of mucosal bleeding. Later on the same day, my pager went off about patient B. This patient had received multiple platelet transfusions over the past few days, and her platelet count was not increasing. When I looked up this patient, I saw that her admission was complicated by a hematoma in her pelvic area that extended into the thigh region, and she also had intraparenchymal cerebral hemorrhages. So because she was actively bleeding, they wanted to keep her platelet count above 50,000. And they wanted to get special platelets for her as well because she was not responding to platelet transfusions. So let's take a step back from our patients and define what platelet refractoriness is. Platelet refractoriness is defined, excuse me, as repeated suboptimal response to platelet transfusions with lower than expected post-transfusion count increments. So in the United States, in my hospital, we mostly use single donor platelets that were donated by apheresis or collected by apheresis. And there are 3 by 10 to the 11 platelets in a unit. We expect an increase of about 30 to 60,000 in a patient. So if we see less than that, then we suspect refractoriness. So if I have a call from the clinical team saying that they suspect refractoriness, the first thing I do is I confirm the diagnosis of platelet refractoriness, and I then go on to try to identify the causes of refractoriness, whether they are non-immune or immune causes of refractoriness. To diagnose platelet refractoriness, it's very simple. I'm looking to see if the patient is getting an appropriate bump or increase in platelets from their transfusion. So we use 2 different formula to determine whether the increment is appropriate. The first formula is the corrected count increment, or CCI. The second formula is the percentage platelet recovery, or PPR. They're very similar formula. They take the patient's platelet count before and after a transfusion, and they look to see if they look at the increment by subtracting the post-transfusion platelet count, or I'm sorry, taking the post-transfusion platelet count and subtracting the pre-transfusion platelet count. So that's the increment. And then you correct for the body size of the patient. So you multiply the platelet, for the CCI, you multiply the platelet increment by the body surface area, and you then divide by the number of platelets transfused. The percentage platelet recovery is similar. You take the platelet increment, you multiply by the total blood volume. So you're correcting for the size of the patient, and you divide by the number of platelets transfused. The CCI has no units attached. If you go through the formula, you'll see that all of the units drop out. And so a CCI of, say, 5,000 to 7,500 is considered refractory. If a patient only has an increment of with a CCI of less than 5,000, then they're certainly refractory to platelet transfusions. Because in my hospital, we mostly use CCI, I'm going to stick with that for this talk. So the first thing I do is I ask for 2 10 to 60 minute post-transfusion platelet counts. I ask for 2 because platelet counting can sometimes have mistakes in it, and also because some platelet transfusions, the unit isn't as good as other units, or because the patient might have a transient bleed, and so the platelets are being consumed rapidly, and I'm not seeing a true increment. I ask that they be done 10 to 60 minutes post-transfusion because you need at least 60 minutes to have the platelets equilibrate within the intravascular space. If a platelet transfusion is transfused into the right arm of the patient and you draw the blood for the platelet count from the left arm of the patient, the platelets that have been transfused may not be fully equilibrated throughout the patient's intravascular space for an hour. Logistically, however, a 1 hour post-transfusion count can be difficult to obtain. We ask nurses to do this, but they often need a greater time span to do it. So we say, please take the post-transfusion platelet count anywhere from 10 to 60 minutes post-transfusion for the CCI calculation. Now, when I was a resident, I was taught that if you had a low 1 hour CCI, it meant that you had an immune cause for refractoriness. It meant that the antibodies were taking platelets out of your bloodstream. However, if you have a brisk bleed, then that can consume platelets just as rapidly as antibodies. So there really is no evidence to support the concept that a reduced 1 hour CCI means that there's an immune cause of refractoriness. There still can be non-immune causes. So it's easy enough to calculate the CCI to simply plug the numbers into the formula. But if it's 3 o'clock in the morning and you're very, very tired from seeing patients, it can be useful to simply go to this calculator online and plug in the information. It asks for the pre-transfusion platelet count, the post-transfusion platelet count, the time after transfusion, whether it's a 1 hour post-transfusion count or a 20 hour post-transfusion count, the height and weight of the patient to calculate the body surface area, and then the number of platelets within the unit. And it will pop out the CCI value for you. So this calculator should be available to everyone listening if they want it. This is the platelet count of patient A from the time I began to follow this patient. In April of 2020, she began with a platelet count of 42 or 46,000. And you can see that she rapidly began to drop the number of platelets that she had, and she began hovering under 10, which we consider to be a trigger for a platelet transfusion in the United States. The first CCI was drawn at this time when her platelet count was 17. They gave a unit of platelets, and her post-transfusion platelet count was 15. So obviously she went from a higher count to a lower count, even after a platelet transfusion. Her CCI value was negative 1,300. So that certainly indicates refractoriness. However, we do ask for 2 counts, just in case, as I mentioned. And so the second count was done for this transfusion, and here her CCI was 700. So that's a better increment, certainly, than when she went from 17 to 15. Here she went from 7 to 8. Still was a very poor increment. This patient is certainly refractory. Patient B, here we see her platelet counts. And when we did her CCI calculations, her first one was 6,900. That is below the 7,500 that I said is the cutoff by many hospitals for refractoriness. And so this patient is also refractory. However, when a second count was taken, her CCI was now negative 1,400. So you can see from these numbers that the CCI can bounce around quite a bit, which is another reason, or another good reason, why you want to take 2 CCIs in a row if possible. So the next thing I want to do after I determine that the patient truly is refractory by getting 2 CCIs less than 7,500 is to determine whether there's an immune versus non-immune cause for the refractoriness. So this slide shows the major non-immune and immune causes for refractoriness. Most patients who are refractory to platelet transfusions, in fact, 60 to 80% of the cases are non-immune, and the reasons are shown here. Infection, fever, bleeding, DIC, a microangiopathic hemolytic anemia such as TTP. Many drugs are involved in non-immune causes for thrombocytopenia or for refractoriness. Splenic sequestration when you have hypersplenism. Graft versus host disease, and of course, if the patient just has received an older platelet unit and it's of poor quality, you do not get as good an increment. The immune causes are shown here. And again, these are rare. They only occur in about 10 to 25% of the cases of refractoriness. But if you see an immune-mediated cause for refractoriness, overall, most of those cases are due to antibodies against class 1 HLA. But you also have cases or contributory factors from ABO mismatched platelets. For instance, if a patient is group B and they have a high titer of anti-A isohemagglutinin, then if they receive a group A transfusion of platelets, then those antibodies can remove many of those platelets from the patient's circulation very rapidly. Usually it contributes about or it will decrease the increment by 10 to 20%, but there are cases in the literature where it has been far more severe and caused severe refractoriness. Antibodies against human platelet antigens, that is seen far more rarely. There are only very few antigens against human platelet, antibodies against human platelet antigens. There are only about 5 common human platelet antigens. And so I think of that as a rare cause of refractoriness. And then antibodies against drugs that have formed a complex with platelet antigens. That is another cause. That is actually far more common than antibodies against human platelet antigens. So to rule in or rule out these various causes, well, for non-immune causes, a good history and physical will allow you to rule in or rule out non-immune causes of refractoriness. A complete history and physical will allow you to rule out bleeding or possible infection. Labs and a physical exam should allow you to rule out DIC. And a review of medications. I've included a very short list of medications that are often involved with refractoriness, but in the next slide, you'll see that there are a longer list. And then you can do imaging studies to help rule in hypersplenism. If you see a gigantic spleen, or if you simply do a physical exam and palpate a larger spleen, that might lead you to suspect that hypersplenism is involved. There is a wonderful website produced by the Blood Center of Wisconsin. They collect every paper that's published that notes that there's platelet refractoriness due to medication. And in this website, they will note the number of times a drug has been mentioned in the literature. This list are the drugs that have been listed more than 10 times on that website. So if it's been published in a paper just once, I think it might just be a coincidence or nothing that I'm going to worry about because it's so rare. But if it's been listed more than 10 times, then I'm going to take that drug seriously as a cause of platelet refractoriness. And I actually keep this list above my desk in my office. So when I get a call about these patients, one of the first things I'll do is I'll review their medications. If they're on any of these medications, I might call the clinical team and say, they're on vancomycin. Can you switch them to a different antibiotic? And if that resolves the refractoriness, then I'm done. I've done something easily to help this patient. So after I've decided whether non-immune causes are involved, I'll then think about whether they're immune-mediated causes. Now, If it's a non-immune cause, such as bleeding, there's very little I, as a transfusion medicine doctor, can do, because all you can do is give platelets. But if the platelets are consumed rapidly by the bleed, then you can't really help the patient other than trying to give as many platelets as possible. But if there are immune-mediated causes of refractoriness, then you can get specialty platelets that lack the antigens that the patient has antibodies against. And that will hopefully help you increase the increment after a platelet transfusion. So because I mentioned that HLA, antibodies against HLA class 1, is the primary cause for immune-mediated refractoriness, I just wanted to quickly go through HLA class 1 and platelets. Platelets, of course, have ABO on their surface, ABO antigens on their surface, and they also have class 1 HLA on their surface. There are 3 loci of HLA class 1, A, B, and C. However, only A and B have been shown to be important in cases of platelet refractoriness. So I'll be limiting my talk to discussing A and B of HLA class 1. So once I've decided that a patient is truly refractory because they have 2 CCIs, less than 7,500, and that there's a potential non-immune cause for the refractoriness, then I'm going to go about trying to identify compatible units for this patient. And there are a number of ways that I can do that. I can try a platelet cross-match to obtain cross-match compatible units. I can screen for HLA class 1 antibodies to see if the patient has multiple antibodies against class 1 HLA, which will increase my suspicion that that is the cause of the refractoriness. I can try and obtain HLA matched or HLA compatible units for the patient. And keep in mind that if the patient has a non-immune cause, such as bleeding, they may also all have antibodies against HLA or other non-immune or other immune causes. So it can be a mixed thing. So even though a patient is bleeding, I might still decide to work them up for immune compatible platelets. So the first thing I'm going to do is I'll look for a platelet cross-match. And the idea of a platelet cross-match is very simple. It is a basic ELISA assay, enzyme-linked immunosorbent assay. You take a few drops from a unit of platelet and you add it to a 96-well plate, and you let the platelet antigens coat the surface of the plate, of the plastic of the plate. You then take the patient's plasma or serum and you mix it on, and you add it to that plate. If the patient has antibodies, you can visualize, those antibodies will bind to the platelet antigens, and you can visualize that binding. And that will tell you whether the patient has antibodies against that platelet unit. If the patient has antibodies against that platelet unit, that's a good indication that that will be an incompatible platelet and will not give you a good increment. If, however, the platelet unit is compatible with the patient, then it might work to help increase the platelet increment. So the advantages of platelet cross-matching: it's a very rapid way to identify a compatible unit. It is an inexpensive test, and you can identify that the patient is alloimmunized, whether it is against HLA or HPA, human platelet antigens. That's not known. The test will not tell you that, but you can at least see that the patient is alloimmunized, that these antibodies are causing incompatibility. But there are some disadvantages too. It can be difficult to find units for highly alloimmunized patients. And you can risk further alloimmunization by transfusing HLA unmatched units to a patient. Another way that you can identify compatible platelets is to get an HLA matched unit. So there are often when we have patients who are going for a stem cell transplant, we know their HLA genotype or phenotype in preparation for the transplant. So we can take the patient's genotype and call to our blood center. We are very, very lucky in that our blood center has already HLA typed all of their frequent platelet donors. So they can look at the unit that they have on the shelf in the blood center and know the HLA type of many of those platelet units. So I'll call over to the blood center and say, we have a patient who has their HLA phenotype is A2, A27, B7, B38. And if they find a donor who has that same phenotype, then that will be an HLA matched unit, and that will almost certainly give you a better increment in a platelet refractory patient. The advantages of using HLA matched units: you're assured compatibility if there are immune causes for refractoriness, and that they are HLA. They are HLA based, and it reduces the risk of future alloimmunization. The disadvantages: you need to have an HLA genotype on record, and if you don't, then that takes time to get it to run that test. You might have a very limited donor pool for some patients. HLA, of course, runs along racial and ethnic lines. In Minnesota, where I work, many of the people are of Scandinavian descent. They're from Sweden or Denmark or Norway. If we have an African-American patient, their HLA type is going to be very different than the HLA type of many of the donors. So that might be difficult to find an HLA matched unit for an African-American patient. And testing can delay access to matched units. If you have a patient for whom it is difficult to obtain an exact HLA match, you can turn to what is known as the antibody specified prediction algorithm. I also call it just antibody avoidance or antigen avoidance. If you have the same patient who was A2, A27, B7, B38, and you found out that they had HLA antibodies against these 5 HLA antigens, if you can't find an exact match, you might be able to find a partial match. In this case, we found a platelet that was from a donor who was A2, A45, B7, and B38. So that A45 is not an exact match, but if you look at the 5, if you look at the 5 antibodies, there we go. If you look at the 5 antibodies this patient has, none of them is against A45. So that should also assure compatibility. And there have been studies showing that HLA compatible work just as well as HLA matched. So that really, the advantages of using the ASP method is you have a much wider pool of donors available. You don't have to have an exact match, and you reduce the risk of alloimmunization if a partial match is available. The disadvantages is you can have a delay in obtaining units while waiting for test results. So now let's talk. I've told you about the patients. I've told you about the testing. I've told you about how to obtain compatible units. I want to put it all together now and tell you about how to manage these patients. This is the algorithm we use at the University of Minnesota. And it's a complicated looking algorithm. And I think for people who are watching this presentation, it would be too much to just go through each box and each arrow. So instead of doing that, I'm going to take you through each step as I do it. Step 1 is to answer the clinical questions first. Is the patient refractory to platelet transfusions? So I order the 2 post-transfusion increments, and I get the CCI values, and I determine whether the patient is truly refractory. I then ask, can I do some good? Can I help this patient? Is it immune-based refractoriness? If it's non-immune, I usually don't touch it. But if it's an immune-based refractoriness, then, or if I suspect that it's immune-based, then I run a number of tests. The first thing I do, because it takes the most time, is I order an HLA antibody test. When we do an HLA antibody test, that begins as a screening test with a single bead assay. We have a bead that is coated with 100 different HLA antigens. And we take the patient's plasma or serum, we mix it with that bead, and if the patient's plasma or serum, if there are antibodies in the patient's plasma that binds that bead, that tells us yes or no, the patient has antibodies against the HLA class 1. If that screening test is positive, we reflex to the single bead assay. The single bead assay has 100 different beads, each of which is coded with a single HLA antigen. We mix all 100 of those beads with the patient's plasma, and whatever the patient has an antibody against will bind to a bead, and that will tell us the specificity of those antibodies. So we can know exactly what kind of antibodies the patient has. We also, from that test, can tell the strength of that antibody, whether it be that the antibody is very high titer, so there's a lot of antibody present that can bind to the bead. Also, whether the antibody binds with great strength, the avidity of the antibody. And the strength of that antibody is displayed as a mean fluorescent intensity, or MFI. So if the patient has a high MFI, that is a higher risk antibody. You could also order an HBA, human platelet antigen antibody test at this time, but because, as I said, it tends to be far more rare that a patient has an antibody against these, I find it to be a low yield test, so I usually do not order that up front. Step 2, I order a platelet cross-match. So while the HLA antibody test is running, I'll look and see if I can find cross-match compatible platelet units. So I will ask the testing center to pull 14 ABO compatible units, and coat the plastic well and run the cross-match assay as I showed you. If 14 out of 14 of those units are compatible, then I abandon the cross-match strategy because there's no advantage, and I'll simply use random platelets off the shelf that are ABO matched to try and support this patient through their refractoriness. If, however, on the other hand, 100% of the units are incompatible, then either it is a highly alloimmunized patient. Remember, our patient had a pregnancy history of 7 pregnancies. Each time a woman is pregnant, she has a risk of developing HLA antibodies, and the more times you're pregnant, the more HLA antibodies you're likely to have. So it could be that the patient is 14 out of 14 incompatible because they have had so many pregnancies, or it could be that they are alloimmunized against human platelet antigen because there are so few antigens. It's likely that every single one of the platelets in that test has that antigen. And so I will consider ordering a unit that is HPA-1A negative. That is the most common platelet antigen against which we see antibodies. And my blood center keeps a list of donors who are HPA-1A negative. So I'll order an HPA. If someone is 14 out of 14 incompatible, I might order an HPA-1A unit and see if that works. That takes a long time to bring the donor in and get the platelets, so I might pursue other strategies at the same time. More often, I don't have 14 out of 14 compatible or incompatible. I have a few that are compatible and a few that are incompatible. So in the cases where I have just a few units that are incompatible, I'll take those compatible units and I'll use them to try and support the patient. When I've selected some compatible units that are cross-match compatible, when I transfuse those, I make sure to order a post-transfusion increment or post-transfusion platelet count each time to determine the CCI to see if it improves with cross-match compatible units. If it improves, then that's how I will continue to support the patient. If it doesn't improve, I will try 3 cross-match compatible units. And if it doesn't improve with all 3 units, then I know that that strategy is not going to work for this patient. But I always try 3 in a row because, as I mentioned, CCIs are variable, platelet units are variable, patients are variable, and it's worth it to test 3 different units. Step 3, if the cross-match assay if the cross-match compatible units do not work, or I cannot find cross-match compatible units, I'll turn to HLA compatible units that are also ABO compatible. And of course, a 4 out of 4 exact match is the best if I can find it. If I cannot find a 4 out of 4 exact match, then I'll use the antibody avoidance or ASP method to find a compatible unit. And just as with the cross-match units, I will do a pilot run of 3 HLA matched units or compatible units and see if it improves the CCI. If the patient's CCI does not improve, I will go to more extreme measures. I'll consider calling in family members for directed platelet donations, because if the patient is from a smaller ethnic group, it might be that they benefit from a family member who might be an exact match for them, HLA-wise. I also will consider transfusing units that do not honor antibodies that have a low MFI. Remember, I mentioned that MFI indicates the intensity of the antibody. If a patient has a lot of antibodies, I may not find a good match. So I can't honor every antibody the patient has with antigen negative units. So I'll start to pick out the antibodies that are more important and test the ones that I might get lucky and find that some antibodies are more important than others. I'll also ask the blood bank to give me the freshest units possible, because I found, and it's been shown in the literature, that the fresher the units are, the better the increments are. So I'll prefer a day 2 platelet to a day 5 platelet. And of course, I'll try and use ABO compatible units whenever possible. I'll continue to follow the patient closely until their thrombocytopenia resolves. So here again is that algorithm. If you want, you may have access to these slides if you ever want to use this. But I'd like to bring us back at the end to the patients. We established that both patient A and B were refractory to platelets, to random platelets. So we tried a platelet cross-match. For patient A, we found that she was incompatible with 14 out of 14 donor platelets, indicating either that she was alloimmunized to many HLA antigens, or she had antibodies against HPA-1A or HPA-5B. Patient B was bleeding, but because she was not doing well, we decided to just test her anyway to see if there was an immune component, if we might be able to help her in some way or another. She was incompatible with 4 of the 14 donor platelets tested, so she was compatible with 10 of the 14. So we were able to test her for with 3 units of cross-match compatible platelets, but unfortunately they did not work with this patient. The CCIs did not improve. So for both patients, we turned to look for HLA compatible units or HLA matched units. So here's the HLA results from patient A. The screening test was positive. So she did have HLA antibodies, and of course that reflexes to the single bead assay. And here you can see that she had a large number of high-risk antibodies against class 1 HLA. She had, you could see A1, A2, A23, 24, 25, 26, 32, etc. She also had a few moderate risk antibodies. So this patient was highly alloimmunized, and obtaining a platelet might be difficult for this patient. However, for patient B, we also did the HLA antibody test and found that she was negative. So we didn't go on to the single bead assay, of course. So patient B was not alloimmunized at all. So back to patient A, we were lucky. We were able to find 3 units that were a perfect match for her, because remember, she was going for a stem cell transplant, so we knew her HLA type. So we were able to find HLA units that matched by A3, A11, B7, and B8. And the response, I'm sorry, that's a typo, that's spelled wrong, but patient A, we obtained 3 units that were HLA matched, and she had a good response with a CCI greater than 7,500, and we were able to get her platelet count above 20,000 as the clinicians wanted. Patient B, there were no immune causes for platelet refractoriness identified. Likely her head bleed was consuming all of the platelets that she was transfused. We continued to support her with random units, but unfortunately, we were not able to help with her head bleed, and she passed on. So in conclusion, platelet refractoriness is usually caused by non-immune factors. But if you have a multiparous patient, they're more likely to have antibodies against HLA class 1, which can cause immune-based refractoriness. Patients with immune-based refractoriness can be managed with cross-match platelets, HLA-matched platelets, or HLA-compatible platelets. And it is very important to track the patient's response to matched or compatible platelets to identify the best product to use for each patient. These are some references that I used to put this talk together. And I want to thank the audience for listening to this presentation. And once again, thank the organizers for inviting me to give this presentation.
Thank you. Thank you both for your presentations. Very interesting topics. And we are full of questions by the audience. They are really interested to discuss with you some topics. I will begin by some questions for Dr. Sergio Sánchez. Some questions are about what you did and what happened with the case you presented. I understand that this was not your patient, but do you know what happened with this patient, that her blood type continued to be the one she had before? So she had ABO incompatibility. That's right. The latest information that was over the phone was that they require less transfusions and they were with a lesser frequency, not every 2 weeks, but she still hasn't changed her blood type. But yes, this was over 6 months, which is far more than expected. And also another question, your experience in all the time you spent at the Cancer Institute, how often did you have patients with pure aplasia and ABO and Rh incompatibility? Well, the literature describes a frequency between 20 and 50% of allogenic transplants with ABO incompatibility, but the truth is I don't have my own statistics. However, I think we are towards the 20% line, that of 50%. I would like to assume that this is because the most common blood type in the Mexican population and Latin American population is the O blood type. And actually, our native indigenous population of the whole Americas is this group. A and B came along with the Spaniards and with mixed races. So it is not 50%. I would say 20, 30% at the most, divided between major and minor incompatibility. Bidirectional, no, I don't think I saw this with a donor or recipient. These were more major or minor incompatibilities. For Rh incompatibilities and other antigens, no, although these are not common and certainly they are not as complex to manage as the ABO incompatibility. If you follow your protocols of titration of isohematoglutamines and favor as much as you can peripheral blood so there will not be erythrocytes contamination, I think this could be easier. And other than the case that I presented, I'm sorry, I don't have all the information for this patient. Okay, thank you. And I would like to take the opportunity, if Dr. Cohn, do you have experience in these cases of red series aplasia and incompatibility, and how you have managed these patients?
I'd like to repeat that back to make sure I understand. pure red cell aplasia? Is that what you're asking about? Yes?
Yes. By ABO incompatibility in bone marrow transplant.
Yes, we do see pure red cell aplasia where all of the other lines and grafts, the patient has platelets and white cells, but the red cell line isn't engrafting. And we see it most often when, in cases, we do apheresis. And we have performed apheresis. I remember an 8-year-old boy where we performed apheresis over and over and over again because his titer of anti-A was so high. And we were able to finally get to a point where he was making his own red cells, and they were group A red cells. So that was very nice.
Thank you for that, doctor. And there are several questions regarding refractoriness platelets, and this is due to the lack of access to diagnostic tests. In our daily practice, it's difficult to have a quick access to have anti-HLA antibodies and to have platelets according to these HLA. So in this context where there is no possibility to do so, which are the recommendations you can give us?
I think the best thing that can be done is to watch the patient very carefully and work with your transfusion doctor very carefully, because if the patient gets a good increment from one platelet unit, then you can call the blood center and find out who the donor was and bring in that donor more often. We do that in many cases where we're lucky. We find a unit that happens to work, and the donor comes in over and over again to donate platelets. Family members are also can be an important source of platelets for these patients. The danger is if the patient becomes alloimmunized to minor HLA antigens, and you can't then help the patient if they need another stem cell transplant, for instance. But if you just want to get them through that one period of refractoriness, I'd say family members can be a very useful source of platelets.
Yes, thank you. We have other very interesting questions regarding your formulas to calculate refractoriness. The questions is if we can use these formulas in pediatric patients as well as in adult patients.
That's a great question. And yes, as far as I know, they work just fine as long as you're correcting for the size of the patient, which is part of the formula. Then yes, you should be able to use it for pediatric patients. Neonates, I actually don't know the answer. I've never had a neonate who is refractory, and certainly not for immune causes, because the only time the neonate is going to have antibodies is if they come from the mom and they have neonatal alloimmune thrombocytopenia, in which case we have found that if we just transfuse the baby with platelets, that those platelets will soak up the antibodies. There's a limited reservoir of antibodies from mom, and you give one platelet transfusion, it soaks up those antibodies, and then the next transfusion should work. Does that make sense?
Yes, thank you. And another question, and I would like to hear both of your opinions. First, Dr. Claudia, and then Dr. Sánchez. Is it possible to predict if a patient is at a greater risk to develop platelet refractoriness, and if a patient that previously had one, would this be persistent, or following different cycles of treatment, the patient will not have more refractoriness? And if so, if the patient is candidate for transplant. Dr. Cohn, could you answer first that?
Yeah, I'm sure that you have probably experienced this. There are some patients who simply make antibodies better than others. And once they start making once we see that a patient has one antibody, there is a greater risk that they're going to make more antibodies. So I worry when I see a patient who, I think of it as an allergic phenotype. They seem to be allergic to a lot of things. They're hypersensitive. And I worry about these patients the most. I think that they still could be a candidate for a transplant. I've never heard of that being used as a reason to exclude a patient from transplant in my experience. But it certainly is something to think about, and maybe at least where I am, where I can get testing done, I might get their HLA type faster and see if I can arrange more platelet donors earlier.
Thank you. Dr. Sanchez, would you like to add to that? Well, yes, thank you. My experience in the Cancer Institute was due to a thesis of a postgraduate student, and we had the opportunity to determine anti-HLA, anti-HBA antibodies in those patients that we were suspecting refractoriness. And yes, as Dr. Claudia Cohn presented, most of them were just left in the suspicious result. And those that were able to document, they were tested for anti-HLA and anti-HBA. Now, this research work was done before we had leukodepletion by filtration, and we noticed a strong reduction in the risk for platelet refractoriness when we approach leukodepletion and universal filtration when we fraction blood. This caused a strong reduction to the need for constant transfusions in patients. And it is always better to prevent in such a way that the reduction of the threshold for a prophylaxis transfusion in patients, it worked. And it works to prevent these overtransfusions and these greater risks to expose the patients to a constant antigen load. All of these endorsed by the Transfusions Committee. And when the patient had refractoriness to the impossibility to have cross-matching with HLA, we tried to contact their families as platelet donors, and we used these platelets only for therapeutic transfusion and not prophylactic if the patient was in stable clinical conditions. Yes, Dr. Meillón, you had a question? Yes, I would like to ask Dr. Sánchez. Certainly, the elimination of leukocytes in these products is valuable both to reduce sensibility as to reduce the transmission of CMV. But I would like to ask, these filters, third and fourth generation, how is their availability in our country and in public institutions? Are these filters frequently used or only leukodepletion by centrifugal process? Do we know how we stand in Mexico with this? And also, following this idea, radiation of products to reduce the risk of transmission with host. Also, how available are the radiation equipment for these products? Yes, we have both in good availability in our country for so many years now. When I left the cancer institution and was incorporated at the Nutrition Institute in 1993, at the blood center, the first filters were already in the market. These were third generation filters. Marca Baxter was the brand. But these were only for use at the bed of the patient. And then filters were developed for their use in the laboratory. Currently, we have blood bags, and when they are in the centrifugal machine, and this is the most efficacious method, but these are expensive. When I proposed them in the public tender in the Cancer Institute, I was called upon to the general direction to explain my reasoning. And this reduction in the use of blood products for refractory patients was worthy and justified a cost increase. They are justified but are expensive. Now, for radiation equipment for blood products, certainly it is necessary for these purposes. And yes, their cost. And the requirements as well in order to install these are so many, but it can be done. And these are some of the reasons why accelerators are used to radiate blood products, but this is not the best recommendation. It is always best to have the radiation equipment for dedicated radiation equipment for blood products, but for nuclear safety with cesium-137, they could be easily stolen to generate enriched uranium and use this source as a material for weapons. A few years ago, the US government, concerned by this, limited and applied extreme security in the radiator here in the blood center in the Cancer Institute. Because of this, an option that is a more recent option is the use of pathogen inactivators, Mirasol, Intercept. Then there are studies conducted that report that they inhibit lymphocytes and the risks of this grafting, but these are also expensive. And this is a unit by unit method. This is an option for us, but for weekends or holidays, or when we didn't have a technician, if the technicians were on vacations, that were the times when we use these agents. Okay, thank you. Thank you for your explanation, Dr. Sánchez. I think this topic, talking about the filters, it's really important. And I think that physicians, hematologists in particular, we are the ones that ideally we could argue and explain to hospital administrators that regardless the high cost of these filters, actually the reduction and of every issues of leukocytes contamination justified and sometimes even are help us save funds. And this is a good argument to convince the administration staff to have these filters. Thank you. Yes, we have a couple of questions for Dr. Cohn. Is there a pharmacological strategy that could work out with patients with platelet refractoriness?
Yeah, there are platelet agonists available that they work if the patient has good kidney function, and I actually don't know how often they are used because it's expensive, and it also, if used over a prolonged period, can cause bone marrow fibrosis. But they are available. I think that there are now 3 or 4 different thrombopoietin agonists on the market that are safe and work well. I think it does take a few days to work. And of course, you need to have a marrow that's working well. So in some patients with leukemia, that might be a problem. Or patients who have undergone a stem cell transplant, it would be a problem.
Yes, and a question for Dr. Sánchez, a similar question, but in a different context. In the context of a patient that has suspicion of red puraplasia, and how effective would be plasmapheresis plus minus hemoglobin or rituximab? Yes, I know if titrations are elevated, the option would be to decrease them, as Dr. Cohn was explaining, with apheresis from the recipient. And once proven that at least there are some precursors of red series in the marrow, yes, in this case, it is an immune cause. So the suggestion is a modification in the immunosuppressor scheme. Okay, and a very last question for Dr. Cohn. Perhaps it is not the topic, but which would be your suggestions as for the management of prophylactic transfusions in patients with acute leukemias? Which is the threshold for transfusion in these patients?
I think the data are good that 10,000 is safe for most patients who are stable, not bleeding. And I also think it's very interesting that there were 2 studies that looked at whether to use prophylactic transfusions or not for patients. And they both found the same thing, that there is a somewhat increased risk of bleeding if you only have therapeutic transfusions, not prophylactic. One study by Dr. Wendt in Germany decided that that risk was worth it and that you should only go with therapeutic transfusions, that prophylactic wasn't as important. Whereas Dr. Stanworth in the United Kingdom said that the risk that he found of bleeding was too great a risk and that prophylactic transfusions should be used. So 10,000 is the number we usually use. I think there were early studies by Dr. Schlichter showing that patients need about 12,000 platelets a day if their endothelium is threatened by chemotherapy, for instance. And there were also studies by Dr. Rubella in Italy showing that if you look at 10,000 versus 20,000, that 10,000 is safe.
Yes, thank you, Dr. Cohn. Dr. Sanchez, would you like to add something? Yes, well, I insist. As long as we can prevent and support ourselves in the transfusion committee, transplant committee, always go along with the scientific principle, because if we are waiting for a standard, we could spend years without it. So we don't need anybody to tell us how to do things. We are the ones that know more than the legal party. And as Dr. Meillón was saying, we should be updated and not leave every decision to administrators. Justify and endorse ourselves based on scientific publications. Well, thank you very much. We have reached the hour. Thank you very much for your participation. And I leave Dr. Meillón the floor for a closing statement for this session. Thank you very much. I think this has been a very interesting and useful session. Transfusion medicine between clinical hematologists sometimes is not as appealing as leukemias or lymphomas or oncological patients, but certainly is critical for a proper patient management. And these issues, problems that we have discussed tonight, I think are very important. I am really happy. We have had a very good audience. A little over 700 attendees are connected in today's session, and this is proof that there is a lot of interest in these topics, and we are happy that we can include them in the academic programs of the Mexican Society for Hematology Study. Thank you very much. Thank you, Dr. Cohn, for your participation, your comments, and Dr. Sánchez, we have known for some years now. He's a good friend also. Thank you. Thank you for your presentation and your comments, and to you. Thank you very much for joining us tonight in this session. We will see us soon, as Dr. Demichelis presented, next Saturday to talk about graft versus host disease. Thank you. Good evening. See you.